Welcome to the Royal College of Physicians Edinburgh Clinical Conversations podcast. Each episode within this podcast series, we delve into a different medical topic with an expert speaker to join us. If you want to find more about the Royal College, then please do head over to the RCPE website and have a look at the education stream and see if membership would work for you. It offers a host of educational updates and activities such as the evening medical updates, the Royal College Symposia, and many more. Please don't forget, if you listen to our podcast, to give us a rating on one of the podcast platforms or subscribe so that it can come directly into your podcast stream.
Hello everyone, and welcome to another episode of Clinical Conversations brought to you by the Royal College of Physicians of Edinburgh Trainees and Members Committee. My name is Dr Marilena Giannoudi and I am on the TNMC, and today I'm delighted to be joined by Dr Heeraj Bulluck, who is an interventional cardiologist at Leeds Teaching Hospitals and has recently developed an interest in preventive cardiology, and we'll be talking a bit about why that's important and why we need to be thinking about a shift from treatment to prevention. So Dr. Bulluck, good morning, welcome, and thank you for joining me.
Thank you, Marilena. I'm delighted to be here. Thanks for the invite and looking forward to our chat.
Me too. So I guess let's get straight into it. For me, the best place to start is, as I mentioned to our audience, you are known as an interventional cardiologist, so on the front line, treating heart attacks in the cath lab, but you've recently developed this interest in preventive cardiology. So can I ask, how did that come about and why do you think that this is important?
Thank you. Yeah, that's a very important question to me, actually. So over the years, having treated heart attacks in the cath lab, nowadays I'm seeing patients presenting at a younger age, and some of them younger than me, in my 40s. We work very hard in the cath lab, to patch the artery, and then afterwards reinforcing all these secondary prevention measures. And then it made me realize a lot of resources are invested after the damage is done, and maybe moving the treatment and prevention strategies upstream before disease manifests would be a better strategy. And that led me to think about optimizing my heart health myself. And along the way, I thought I should spread the message. What can we do about optimizing our heart health, especially in midlife, in our late 30s, 40s, and 50s? This led to me writing the book Heart Reset 40.
Okay, thank you. So is preventive cardiology about optimizing risk factors? And if so, how do we know what our risk factors are?
Thank you. So probably coming from me being an interventional cardiology, probably I would call preventive cardiology being an early intervention cardiology. So it's more about intervening before disease manifests itself clinically. And this can be quite challenging because a lot of us, we feel fine most of the time and we don't realize something is happening. The first sign is usually the symptoms of a heart attack, but usually this is the last chapter of the book. When someone presents with a heart attack or angina, disease gradually progress over time. So to answer your question, preventive cardiology is more about identifying risk factors early and acting on them early with lifestyle changes, small habits we can easily implement and compound. And then eventually that can change the trajectory of disease in the future. And the second part of the question is, how do we know what our risk factors are? This, again, when we are in our 20s and 30s, we don't really think too much about it. But usually once we are in our 40s and beyond, suddenly there's this shift in our, for example, energy levels, our sleep patterns are a bit disrupted, we're a bit more stressed, our waistline starts to creep. The GP might tell us our numbers are borderline in terms of blood pressure, cholesterol, and glucose, or HbA1c as we call it. So this is the time when we can probably identify certain, as we call it, risk factors or certain parameters we can act on early before they become irreversible, and that eventually leads to irreversible damage in terms of plaque formation, inflammation, plaque rupture, heart attack, and stroke.
And so, what is the best way of identifying them? Because you said the GP might tell us something, but lots of people may not go to the GP. Do you think we need to increase opportunistic screening? Do you think we just need to get education out there? Because there's so much on the internet or with smart devices, whether it's your watch or your phone, we should be tracking our kind of risk factors through that.
Yeah, so this is the basis of the contents of my book, Heart Reset 40. So the idea is not only the patients we see, but ourselves, if we're in our mid-30s, 40s and beyond, is first of all, to know our numbers. Education is important. What are those numbers and what do they mean? And there are simple things like blood pressure, for example. So a lot of people don't know what their blood pressure is until they present to A&E. And so simple things, I wouldn't say you need to start worrying about it in your 20s and 30s, but once you are in your late 30s and beyond, it's important to start knowing what's your blood pressure like, what is your lipid profile. Normally in the UK, you have a NHS health check. For men in the 40s and women in the 50s, they will get a free health check. So it's important to probably attend those and get a baseline idea of your numbers. Those will be your lipids, specifically your HDL and your HbA1c. So already there are three numbers there: blood pressure, your LDL, and your HbA1c. So there are certain normal range, which I mentioned in the book. So if your numbers are okay, it's a good chance to maintain what you're doing and make sure that doesn't go in the right direction. If the numbers are borderline, then it's time to act now, early, before you have symptoms, to improve those parameters with time. And as you say, tracking. So if you have borderline numbers now, it's important to implement some lifestyle changes now and then eventually recheck them at certain time intervals, depending which parameters we're talking about.
And would I be right in saying that actually the European Society of Cardiology, the ESC, has got quite good guidelines in what we should be advising targets to be, depending on age and pre-existing risk factors that we can refer back to as well?
Yes, definitely. So there are various guidelines out there. Yeah, one of them is the European Society of Cardiology. So there are cutoffs even for healthy individuals, stratified by age, gender, and ethnicity in some cases. And yeah, that would be a good resource to refer back to. And one other parameter I haven't mentioned would be it's your waist circumference. So that's a good marker of your metabolic risk above and beyond your BMI. So that's another number. And what is your normal range, or should be? There are reference range out there depending on gender, ethnicity, and that's a good number to track as well, because that indirectly will indicate how much fats are on your vital organ, the visceral fats, which are usually the active form of fat. And those are the ones that lead to metabolic syndrome or insulin resistance and the downstream consequences.
Okay. And for our listeners, I'll put a couple of those kind of risk stratification profile guidelines in the footnotes of this podcast. I think you've already alluded to this, but when should we start making these lifestyle changes? You mentioned something about, you need to be aware of it in your early 40s. Is that when we have to be strict with ourselves, or does the work start before then?
Yeah, so I think you're right. The work should ideally start before then. In an ideal world, the earlier we start, as a kid, teenage, developing those healthy lifestyle as part of normal habits, that would have been ideal. But this is not the case in real life. We tend to drift into, say, unhealthy lifestyle in the 20s and 30s. Usually our body is more forgiving and can adapt. But it's in midlife, so it may be mid to late 30s to start with, when the metabolic shift that happens, hormonal shifts in our body, when the implications are more important. So I would say if you had to choose now, it would be in your late 30s, but it's not too late to start in your 40s and 50s. If anyone listening to us are in that age group or even the 60s, it's never too late. But the idea is that decade of opportunity, which is in your 40s and 50s, depending for men and women, is when those small micro habits we can talk about that can compound, and the potential benefit is much higher in that decade compared to doing the same intervention 10 years or 20 years later. So yeah, to answer your question, the earlier we start, the better. Atherosclerosis does not begin in midlife. Usually they start in our 20s. There has been studies looking at autopsy of young adults involved in road traffic accident, for example. 1 in 5 of them would have signs of early plaque formation, like those fatty streaks in the vessel. And so usually it accelerates when our health routines erode, as I mentioned, in late 30s and 40s. When our work intensity increases, sleep becomes irregular, movement declines, and stress becomes chronic. So from a clinical perspective, the trigger is not age, it's a change in pattern. And when patient says they feel fine, but tired, when blood pressure or lipids are borderline, when weight has crept slowly over the years, this is the moment of highest leverage. And those are the years when small, sustainable change compound. Waiting for symptoms often means we've missed that window.
And obviously, these are all, to an extent, I guess, modifiable risk factors. But how can we manage, or is there a way to manage genetic risk factors, such as family history? Because I think we'll have all come into contact with patients who have said, I'm so healthy, I watch what I eat, I do this, I do that. And actually, the big risk factor that pops out when you're taking a history from them is, oh yes, my father had a heart attack in their 50s and my grandfather had one in their 60s. And you think it probably is just all family history without having, a formal diagnosis of familial high cholesterol or, something similar to that. So how important do you think our family history actually is?
Yes, so I think family history is very important, partly because it depends on what mindset those patients would take. Some would say, oh, I've got strong family history, I'm doomed, so no matter what I do, I will have a heart attack or a stroke. Others might say it's an opportunity to start early. So family history sets baseline risk, but it doesn't decide an outcome on its own. So genetic influence, such as cholesterol handling, blood pressure regulation, insulin sensitivity, and inflammation. So those can be decided by genetic influence. But those genetic risks express themselves within an environment we live in. So what we see clinically is that patients with strong family history often benefit the most from early prevention because their risk is identifiable early, much earlier than the general population, and can be modified over time. So a helpful way to frame it is that family history explains why risks may be higher, but our lifestyle, behavior, environment, and early intervention largely decide whether it becomes disease. In the book, there is a sentence I use which says, gene loads the gun, but lifestyle pulls the trigger. So we may have the genetic risk factors, but what we do in our lifestyle habits may influence whether we take the path of, to thrive in the future or decline and deal with a crisis afterwards.
You obviously mentioned the factors of LDL, HbA1c, and waist circumference as the big things that we need to be targeting. What lifestyle changes do you think are the most effective at optimizing these risk factors?
Yeah, thanks, Marilena. So yeah, you're right. The easy parameters, as you mentioned, would be LDL, HbA1c, your waist circumference, and blood pressure. It doesn't require you buying an expensive gadget. You just need a blood test from a GP and a tape measurement and a BP curve at home. In terms of lifestyle changes, so the most effective changes are not extreme. They are usually the ones that can be sustained. They are repeatable and can be sustained and compound with time. So from a cardiovascular standpoint, the highest yield intervention are, first of all, I would say regular low intensity movements, for example, brisk walking. Even if you manage to do 20 minutes a day, that's an effective way of improving our blood pressure, our insulin sensitivity. It reduces the triglyceride, improves our HDL, and eventually reduces ApoB, which some of the audience might be familiar with, which is the atherogenic particles, which eventually impacts on atherosclerosis. So that would be one intervention, brisk walking every day. And it doesn't need to be dedicated time. It can always be small interventions such as park a bit further away from work or the supermarket. It gets you to do a few steps, take the stairs instead of the elevator. So that's another way to add these micro movements, eventually compound at the end of the day. Secondly, I would say sleep consistency rather than sleep optimization. So setting set bedtime routines to go to bed at a particular time, no screen for an hour before bedtime, ideal room temperature, which I mentioned in the book. So these are certain things that make sure our sleep consistency is there. Although I understand as doctors, we have shift patterns and this is not always possible. Hence, I'm not focusing on sleep optimization, but at least being consistent with it and aiming when we can, at least 7 hours, which is not always possible, but that's usually what's recommended. So that's something to bear in mind. I mentioned walking, sleep, and thirdly would be what we put on our plate. So the main culprits, as we've heard it in the news and everywhere else, is to reduce the amount of ultra-processed food we eat. So that's a big factor. If we can reduce what's in our plate, ultra-processed food, sugary drinks, and things like cured meats, which is rich in sugar and in salt, and adding things, usually I would advocate the pattern of diet, which is more like Mediterranean style diet. So lots of fresh fruits and vegetables, beans, legumes, olive oil, avocado, or 2 portions of oily fish. So if by adding those good food, eventually naturally makes us avoid the unhealthy side of foods, which I mentioned, ultra-processed food, sugary drinks, cured meats, and even alcohol. So this will be the third intervention. The fourth and final one, I would say, which is, the easy lifestyle change we could do, is not eliminating stress. We can't avoid having stress in our life, but finding ways to manage stress better to prevent it from having any biological impact on our health. So, for example, make sure we have dedicated time to do some activities where it can help us to wind down. For example, just going for a walk, again, it ties down. Make sure we have a good night's sleep may help with stress as well. It ties up to the other measures I mentioned. Or sometimes just doing a few minutes of breathing exercises. So there's box breathing or different type of breathing exercise you can do. So if you take a pause and just do some breathing exercises or mindfulness, sometimes that can have an impact on how we cope with stress better. So these would be the lifestyle changes I would say can make the most difference with the limited time we have. So these behaviors act on multiple systems simultaneously. So it will improve blood pressure, insulin resistance, inflammation, and autonomic tone will all shift together. And what matters most is not intensity, it's more about consistency that compounds over time. And it is whether this change can fit into our busy lives is what matters. Hence, I suggest these small things that we can easily incorporate that eventually compounds with time.
Perfect. I guess the only thing that's in the back of my mind, and is probably the only thing that really left to cover, not that preventative cardiology is such a small topic, but at what point do we say, I've tried everything, I'm doing as much exercise as I can, I'm trying to get my sleep, I'm trying to drink my water, I'm having my Mediterranean diet, but those risk factors are still through the roof. So, your blood pressure is still uncontrolled, your LDL is still high, you're not losing weight. At what point do we need to turn to medical therapy as a form of prevention? Because I think some people say, okay, go away, do diet and lifestyle for 6 weeks, for 8 weeks, and come back and we'll reassess. Is there a set timeline that we need to be reassessing these risk factors?
Yeah, that's a very important point, actually. So medication should not be framed as a failure of lifestyle. It usually works together. It is risk reduction. So lifestyle will change the risk factors gradually over time, whereas medications will lower risk, usually quite much more quicker. So medication therapy becomes appropriate when risk remains elevated despite reasonable lifestyle we've mentioned. Or for example, there's a strong family history, then in those situations, we have to start medication quite early because lifestyle alone will not impact biology. Or when markers are drifting upwards over time, so you say at what time point, I would probably say over 6 months, 1 year, if your markers are still drifting in the wrong direction, or when you've had imaging or risk assessment showing subclinical disease. So whether someone had a coronary calcium score or they've done a Q risk, and that is advocating use of medication, I think that would be a good time to add it on top of lifestyle. Used early, and appropriately, medications reduces lifetime exposure to harm and often prevents the need for invasive treatment later. So the most effective strategy is not always lifestyle or medication. It is sometimes a combination of the two, introduced in the right order in the right time.
Yeah, we are doctors. We sometimes need to give medications, don't we?
Yeah, indeed.
Great. And very quickly, without wanting to open a can of worms, what is your take on weight optimization through injectable therapies? And do you think that this is needed as a way of optimizing prevention?
So I think that would be a good example of what we've just talked about. When is medication required? So I think there is a role for these injectables for certain patients if they've tried all the lifestyle measures and if their weight is still in the red zone or not going in the right direction, then there is a role to complement lifestyle for a short time, I would say, and then reassess. It's not a long-term solution on its own. It should work together with lifestyle intervention after having tried it. There is a cost implication, but for some patients, I think it will be beneficial. It needs to be individualized and you need to reassess, and it should be considered as a short-term bridging therapy rather than a long-term solution.
Thank you. I'm glad you said that. And maybe that's because it's my own personal opinion as well. But I think when we are coming into contact with these patients and having these discussions with them, it is important to focus on the fact that this is short term. Because I think a lot of patients then, think they don't need to carry on with all their lifestyle measures because the injectable therapy will just do what they haven't been able to do themselves.
Indeed, yeah, I agree with that. And also one thing to mention is this is a relatively new therapy and there's not long-term data of the implications, what happened in people staying on the long term. So it's still a space to watch. And as you said, it's a short-term bridge to eventually doing something more sustainable for the long term.
Perfect. So before we close, what would be your advice to any doctor listening to us, medical student who is coming into contact with patients with high cardiovascular risk? How can we start the discussions and the advice about optimizing their kind of prevention therapy?
Yeah, so I think that's something maybe we all can improve on. I have to admit, I was not really paying attention to this before I developed an interest in this recently. So I think the ideal candidates, what I see in clinic, I'll just tell you my own experience, are someone in their 40s, they've come to see me with non-cardiac chest pain. So I've kind of reassured them it's not cardiac, but they have certain risk factors. They're borderline blood pressure, their HbA1c is in the pre-diabetic zone, the LDL is not optimal. So usually I will have a brief chat with them. It's not usually one intervention that fits everything. Sometimes they will say they are doing everything right, but when you probe them, or their sleep is not great, or they got, quite a lot of stress in their life and the coping mechanisms are not there. Some of them may be exercising, but it's not about the volume of exercise. For example, they can't just exercise an hour in the morning and then you sit at the desk for 8 hours. So sometimes you have to, every hour you sit, ideally you should walk around for a couple of minutes and break that down. So those kind of things, actually I've summarized that nicely in my book, Heart Reset 40. Usually I would advise them on these various aspects, on their sleep, eating, on their stress management, movement. The idea is to develop a routine so that it becomes part of your daily life rather than something you need motivation to go and do. And if you don't have motivation, you drop off it. So the idea is it becomes part of your daily life. It's small changes. And then tracking, as you mentioned at the beginning, tracking is important because we can't drive a car without a dashboard to know what speed we're going, how much fuel we got left. So tracking is important where we stand now. It should not become like an obsession, but it's a guidance of which direction we're going and what we need to change to kind of improve those parameters. So that's all summarized in the heart reset 40, which is a good resource, but you don't need to get that. What I've just mentioned, it's a multifaceted approach to eventually improve the parameters now that compounds over time and change the trajectory of disease.
Great. I think that's the best place for us to end it, to be honest. So thank you so much for your time. Thank you for your knowledge. And thank you for giving us tips that we should not only take forward for our patients, but for ourselves. Slightly worrying about how important sleep is, I think, for anybody working on an on-call rota. But I guess it just means that it's a wake-up call that we should all be looking after ourselves because it will have implications on our health kind of later down the line.
Yeah, that's probably a good closing line, Marilena. I agree with you. And yeah, it's not only for the patients, but also looking at our own heart health. And eventually that can help to prevent burnout, which we see a lot in the NHS.
Yeah, perfect. So Dr. Bulluck, thank you so much for joining me. To our listeners, thank you for joining me yet again. For more episodes of both clinical and career conversations, please visit your usual streaming site. I will make sure that footnotes are present for this episode for both guidelines, Dr. Bulluck's book, and any other resources which may help you with preventative cardiology. Thank you for joining me today.